Okay, so now we're going to start this lecture on chapter 14, which is about psychological disorders. And we're going to be discussing what makes a disorder a psychological disorder. But first, we want to talk about why we even bother uh, learning about psychological disorders. And the reason for our curiosity is because you guys all know that when you have seen somebody acting strangely or somebody says that somebody has a psychological disorder, you start to wonder what in the world is happening with them, what's going on. And um, just as our understanding of the brain has increased by studies of damage to the brain, our understanding of the mind can be improved by studying problems in psychological functioning. And even William James, remember him, he's the American psychologist, the first American psychologist, and he said to study the abnormal is the best way of understanding the normal. Like, I'm not so sure that I completely agree with that. However, I think that there is a sense about us that when we see somebody who is just out of what we consider to be normal, we start to wonder what is going on with this particular person. So we all have a tendency to believe in a certain level of civility of behavior or thinking or feelings. But for some reason, when somebody's behaving in such a manner that just seems odd, we start to wonder what's going on. So studying the abnormal, according to James, helps us to understand what is normal. I kind of go the opposite way. I kind of think of the counterfeit money and the idea that somebody who's a good at identifying counterfeit money is somebody who has studied the original. I think even scripture talks about the idea of studying Jesus, and then we know what is right and what is wrong. So that's kind of the basis for why we study the psychological disorders. Now, we're going to do a number of different things. We're going to define what a psychological disorder is. We'll talk about ADHD and some other psychological disorders, and then we'll talk about classifying and looking at the disorders in regards to labeling them. But we're going to kind of ask this question: when do we know something is a disorder? That should be right on your in your thought process right now. What sends somebody over the edge to say, oh, they have anxiety? I'm a little anxious, or I feel a little anxious sometimes, but why is there a disorder called, or why is their behavior called a disorder? So we're going to look at the 3Ds in regards to what we use to define a psychological disorder. So basically, we're going to talk about in here this idea of the basic definition is this disturbance in the psychological, biological, or developmental processes underlying mental functioning. So what does that mean? That psychologically there's a disturbance, or biologically there's a disturbance, and or developmentally there's been a disturbance that influences our mental functioning. Now, when do we find something to be a disorder, and why is it a disorder and not a disease? So the term disorder is used to describe a cluster of symptoms that tend to go together, and that cluster of symptoms falls in a certain disorder. But a disease, by definition, a disease is one that we know the cause of the symptoms, and so we name it a disease. And we'll talk a little bit more about that in a minute. But if you say that it'd be a mistake to assume that you have brain cancer if you had a headache, okay? So in this case, we've got this idea of a single symptom determining what your disease is. So we have to see this cluster of symptoms to say that something would be a disease too. So that quite hasn't distinguished the difference between a disease and a disorder. But in essence, if we said, you have an infection, okay, so we've tested and your white cell count is high, you've got this infection. This infection came from E. coli. So the way in which we treat it is we give you an antibiotic that will kill the E. coli. So the disease is E. coli and the infection, and the treatment is the specific antibiotic. But in regards to a disorder, we might have a cluster of symptoms and we don't really know the cause of them. So we can't say, oh, definitively, we know the antibiotic kills the infection of E. coli, but we don't necessarily know that, this anti-anxiety drug is going to be the answer to your anxiety. So there are some differences there. And we'll talk a little bit more specifically about each of these. Everybody likes the alliterations, and we'll talk about each of these D words to help us to understand how to describe, here's another D word, describe and define a disorder. So we're going to look at the three main D words, and that is dysfunction, distress, and deviance. So when something is dysfunctional, we're going to say that it is a behavior which is considered maladaptive. It's maladaptive because it's interfering with your daily life. So it is dysfunctional. It's not functional behavior or thinking or feelings or emotions, etc. So that's the first one, is that it's maladaptive and interfering. The second one is distress, whether or not it's distressing. And so is the individual suffering because of the distress? And sometimes I say, the people around the individuals are distressed because of the person's symptoms, and so that's causing suffering in others. But nonetheless, the relationships or the individual themselves is distressed. Then finally, we've got deviance or deviant behavior. And so if something is deviant, then it is a disturbance that is going contrary to what we would consider normal behavior. So deviance fits with this idea of abnormal. Now, we do know that if somebody is feeling, if their behavior is deviant and distressful and dysfunctional one day, does that mean that they have a disorder? And we would say probably not. So we're also looking for this disturbance to fit a category or a length of time. It's not just one day I was dysfunctional and distressed and abnormal, but there's a consistent pattern in those behaviors or symptoms. So hopefully that we'll keep going back to these three Ds as throughout the lecture. So let's just take the 3Ds and look at attention deficit hyperactivity disorder. ADHD is this disorder filled with impulsivity and distractibility and fidgetiness and difficulty suppressing impulses. And the question is this a disorder? So based on what we've just talked about, is this behavior deviant? So is it abnormal behavior that somebody has attention deficit disorder? And the reality is that some people have a level of inattentiveness, impulsiveness, and restlessness that goes beyond the normal laziness or immaturity. So it is abnormal. The next question, is it distressful? And is the person enjoying with this energetic behavior? Are they enjoying the fact that they are fidgeting and disorganized and have difficulty suppressing their impulses? And most likely not. And so there's a really good chance that people and or even people around them are distressed because of their symptoms. The final one is the dysfunction. Is the behavior dysfunctional? Are these symptoms harmless fun, or do they negatively impact the individual's work and or relationships? Just think about this. Is it happening just in one day that somebody was this way, or is this a pattern of behavior that's extending over time, almost like what we talked about in personality, but is it over time? And so would we consider this a real disorder? And I think that we can say that in many ways, ADHD is a deviating from the norm, causing significant distress and dysfunction. So we would say that it fits the criteria of a disorder. We do know that it is overdiagnosed because we are not doing a good job, I think, of looking at the differences between what behaviors are normal for a developing individual. So remember, going back to the definition of a disorder is a disturbance of development. Well, there's a really good chance that kids, because over time, they develop at a different rate, and therefore it could be a developmental issue more so than it could be a disorder. So that, of course, is an argument for another day. But now we're going to look at the idea of where these disorders came from and how we diagnose them, and why it's important to diagnose. And it's because it helps us to treat. If we are able to diagnose well, then we can treat well. And we used to have treatments that were very bizarre. We used to drill holes in people's heads to get the evil spirits to come out of them. Beating, caging, restraining, all these kinds of treatments that were not humane. And Philip Peniel came around and he said that this is not right. We should not be doing this to people. That individuals who are struggling with mental disorders may not be dealing with demonic possession, but from other stressors in their life. And if instead we treat them with humanity and love and kindness, we might be able to actually make a difference in their lives. And thankfully, his work did help tremendously. Unfortunately, the discovery that there was this idea of syphilis that created these mental symptoms, this was one of the first discoveries that put us into the market of medical doctors being involved in addressing, or this medical model being developed, because they took this on as, oh, there must be a biological base to everything, and then kind of discounting the spiritual impacts that could be happening to people. Remember, we talked about the biopsychosocial and spiritual components to our disorders, and actually to our development just in general, the biopsychosocial, spiritual. And right now at this point, the medical model's focus is really more of the biological, and so I think they're missing a good part of what makes up a disorder. And so unfortunately, it's not always possible to determine the cause of a specific mental disorder. And so by doing that, we're ignoring some other things that could be influencing the disorder. Psychological disorders, like as seen in psychopathology, or is an illness of the mind, but disorders can be diagnosed, and there are these symptoms that tend to go together, but there's a lot of overlap in the different disorders that we see, unfortunately. And so we can't always be definitive to say that this is what we see. But even if we did, we wouldn't necessarily treat everything the same. So I see a client with OCD and with Asperger's or ASD, autism spectrum disorder. And so the question is, are some of his behaviors, his fixations, involved in, is it because of the autism or is it because of the OCD? And so if it's ASD related, if it's autism related, then I might treat it slightly differently than I would if it was purely just OCD and obsessions and compulsions. So because the overlap can be great, it takes a really good, insightful clinician and not just a medical doctor to kind of tease those out to figure out the best way to treat. And as we've talked about already, this biopsychosocial, I've always add in the spiritual. It's important for us to recognize that there are influences all over the place that are going on today, and it's really does a disservice if we forget about the spiritual. Now, interestingly enough, we do have some cultural influences in what we call culture-bound syndromes. Culture-bound syndromes are disorders that only seem to exist in certain cultures, and these cause a role in both causing and defining the disorder. Interestingly enough, in bulimia nervosa, this is, and if you know anything about bulimia nervosa, it's kind of like anorexia nervosa, but the bulimia is eating and then throwing up the food, binging and purging. And we can date some of that behavior back, I think it was to the Greeks who had the vomitoriums, or the Romans, but that kind of vomiting, eating and vomiting, was different than the eating and vomiting that we're talking about here, because this is a psychological disorder usually related to some level of lacking in self-control. And your last chapter talked a little bit about self and what that means to have some level of self-control, self-efficacy. And so bulimia nervosa is kind of, not to say that we don't see it throughout the rest of the world, but it's kind of more centralized to the developed world and more to the United States. Running amok, now that is a disorder found in Malaysia. And if you've ever heard that term, you're running amok, it actually is violent outbursts that happen throughout Malaysia, and it's not prevalent, but it is unique to Malaysians to have this disorder, in which they just have these violent outbursts. Then finally, hikikomori. This is social withdrawal that occurs predominantly in Japan. So we do see that there are some cultural influences in our behavior. And I also think about, even in the church, if I just came into this room right now and I threw myself on the ground laughing after you spoke, you might think there's something really abnormal, deviant, and distressing about my behavior. However, if you put me inside of a church that is slain in the Holy Spirit and the individuals are very spiritual, this would be normal behavior. So this can be influencing on a cultural influence on this behavior as well. So classifying disorders is can be really difficult, and it's only gotten, I think, in many ways more difficult because of some of the changes that have happened in our diagnostic manual. The diagnostic manual is the DSM-5. It came out in 2013, and this slide talks about the DSM-4TR. And this one, I think, came out somewhere in like 2008, 2007, something like that. And what it does is it helps to classify and the disorders that we have. Unfortunately, there's been a lot of discussion about the DSM-5 as not being a good manual, that it's not evidence-based, so the research does not necessarily support some of these disorders, and some of the disorders are so overlapping, and then they've taken one disorder out in particular. There might be a couple that they took out, but changed some things. And again, there's some critiques that it was not evidence-based in the choices that they made in changing some of the disorders. But it is a manual that we use, and therefore it lists the symptoms of certain disorders. Homosexuality was taken out of the DSM-5 back in the 80s, I think. And so that's not considered a disorder anymore. It's considered, part of normal behavior. And we do still have gender dysphoria. So if somebody is uncomfortable about their gender, then there is that diagnosis there. They added in a couple of really interesting disorders. I'm thinking that there's something about gambling, and let me look to see. I forgot to check this earlier. Oh yeah, so there's caffeine withdrawal is a disorder, and central sleep apnea and disinhibited social engagement disorder. Skin picking is a disorder. Hoarding disorder is also now there, and then binge eating disorder and cannabis withdrawal. So there are a number. There's even others that have been added that some people have argued that they're questioning that disorder. But again, it's a manual that we use, and it helps us as clinicians and therapists and researchers to be using this categorization to talk more specifically about these diagnoses and about individuals, so we kind of know what somebody is referring to when they say, I have an OCD patient. Now, the problem is that there are too many disordered. That's one of the issues, is that we have just so many of them. I think the changeover in the DSM-5 for the number of disorders in the DSM-5 went to 200 and something, 297 in the DSM-4, and the DSM-5 lists, let me see. So the DSM-1, the first one, it listed 106. The DSM-3 had 265, and the 4 had 297. And so we just see this increase of disorders. I don't think the DSM-5 jumped as much as from the 3, but yeah, I can't get the total number. Yeah, I can't find the total number, but the point is that there's just too many things that we have found to be disorders, and that's been one of the arguments. Also, that it's arbitrary, that it's not clear cut in the sense of it's not clear cut in the sense of the borders between the diagnoses. So there's lots of overlap. So one might say, talk about certain symptoms, and another disorder talks about those same symptoms, but then you have to have a couple of different symptoms to kind of separate out the two, and it can be really hard to separate out those. And so there's lots of gray edges between the disorders. And the one good thing about the changes in the diagnostic manual is that we can look at those and kind of get a clear picture. Remember, we talk about this idea of the abnormal helping us to understand the normal. And so kind of classifying what we all consider to be normal or abnormal helps us to know what we all consider to be normal. But again, that's been the argument, that there isn't a clear-cut distinction between that. And again, the value judgments relate to if one of the disorder categories says that the individual has to be experiencing, let's just say, significant sleeplessness over 2-week period. What is significant sleeplessness? Is that the fact that I only got 5 hours of sleep, or 7 hours of sleep, or only 1 hour of sleep? What is that? And so it's a value judgment about what we would consider as disordered versus normal. So what this diagnostic manual can do is it can help us to kind of look at these diagnoses as a way to help us, but also it can help us to reduce some of the stigma. Because when we have accurate information that we can correctly identify individuals' issues, then we can also help to reduce the stigma. That if we start talking about this more, and that a good majority of people are experiencing this, then we won't see it as I'm the only 1% of the population that has this, or that other people have experienced this too, so we can reduce that stigma. It can also help us to understand the realities of certain mental illnesses and the symptoms. So, for instance, schizophrenia is a disorder, but it's not multiple personalities. I see many people say, oh, they must be schizophrenic. They have two personalities. Well, those are two completely different disorders. And so we have to be careful that we know what we're talking about. And so the DSM helps to clarify those symptoms. For example, here's an individual. This is Jared Loeffner. Jared Loeffner shot people, and including a representative. She was a female. She's married to an astronaut. I can't think of her name. She was the citizen, or the, let's see, Jared Loeffner. Let me get that information. So he, Representative Gabriella Giffords, yeah. So she was shot by him, and he has a diagnosis of schizophrenia, but he also has a diagnosis of substance abuse disorder. And so when anybody has both schizophrenia and substance use disorder, the individual is at much a higher risk for violent behavior. So he began using substances in high school, especially when his girlfriend broke up with him. So he struggled with using drugs for a number of years, and even some other recreational drugs. But then he tried to get into the military, and he was rejected. And he admitted to using marijuana on numerous occasions during the application process. He was also suspended from college, and he really struggled there. He did not like Gabriella Giffords. He made some comments that women should not hold positions in power, and so he was really struggling with some of his kind of conspiracy and other kind of unique perspectives. He was, like I said, diagnosed also with schizophrenia. So the question is he responsible for his behavior? And there has been some discussion about whether or not individuals who have schizophrenia are responsible for the behavior. My understanding was he was not taking his medications properly before the shooting. It may have been too that he was also diagnosed with schizophrenia afterwards. I can't remember that. But the question is he responsible for his behavior? And most students will say that he was responsible for his behavior, but that doesn't necessarily mean that he has to be put into a regular normal prison, but instead he should be in a place where he receives therapy pretty much for the rest of his life, though, because he's not safe to be out in the world. So, but just know that schizophrenia alone is not associated with an increased risk of violence, but schizophrenia plus substance abuse can increase the risk. So, keeping that in mind, is he responsible to take his medication? Is he responsible to follow, the doctor's advice and not use illegal drugs? And most people will say yes. So therefore, the appropriate consequence for him would be being in a place where he can't get out, but he will get therapy. So now we're going to switch over to anxiety disorders. Now that we kind of have this understanding of what makes a disorder, or what makes a psychological disorder, by definition a disorder, which is that it's deviant, so that even schizophrenia and substance use would be deviant or abnormal, that it would be dysfunctional and, of course, distressing. I'm sure he was distressed, especially since his girlfriend broke up with him. And, it was definitely dysfunctional in his thought processes. His thought processes were not normal. So now that we know, what makes it a disorder, a psychological disorder, now we're going to look at a different psychological disorder. So we're going to start with GAD. So GAD is generalized anxiety disorder, and it has emotional cognitive symptoms, and it tends to occur. It tends to include, worrying, uh, having anxious feelings and thoughts about many subjects. And you could also even say that somebody had a free floating experience with their anxiety, and they're always anticipating and having difficulties concentrating. So this is the kind of stuff that we're talking about, that these individuals across most settings, across most time frames, they're constantly feeling this way, that there's this generalized anxiety. And GAD tends to occur along with mild but persistent depression. So individuals can also be experiencing depression. And interestingly enough, it becomes more rare after the age of 50. And it seems as though what we find is that individuals who have GAD will be these anxious people, but then as experience happens in life, they realize that the things that they were always anticipating would happen didn't happen. And so then again, that's why we think maybe it stops or really remits a lot after the age of 50. But the physical symptoms, that autonomic nervous symptoms, trembling, sweating, fidgeting, agitation, all those kinds of physical symptoms are just constant. So like if I bang on the table right now, and you jump, then your autonomic nervous system is responding. And just think about how you're feeling right now with that loud noise. This is how somebody with GAD feels all the time, or most of the time. And so how do we deal with that? Well, we can do a number of things. We can provide some psychotherapy. Psychotherapy is going to be helping individuals kind of talk through their experiences, to kind of reframe their thinking. Remember our thinking chapter. And also they're going to kind of address their emotions, identify their emotions, process their attachments, all those kinds of things in psychotherapy. But then you could also just say, well, let's go to the biomedical therapy, because we know that those neurotransmitters are not working properly, and therefore we're just going to go ahead and do medication. Well, the reality is that the research shows that it is so much better to do both psychotherapy and biomedical therapy together at the same time. It's definitely more effective. So the next kind of anxiety disorder we have is a panic disorder. Panic disorders can feel like you are truly dying. This is not just an anxiety attack. This is a panic disorder, or panic attack. So many minutes of intense dread or terror. You can't even comprehend the pain, the sense of numbness, the feeling like you just need to run, and this is just incredibly overwhelming. Now, some people may just have one panic attack and be done with it. There are others, unfortunately, that get diagnosed with a panic disorder because it happens repeatedly and unexpectedly. And there's often this fear of, oh my goodness, if this happens again, what am I going to do? So that is a panic disorder. That we see that regularly. So we've got that generalized anxiety that we talk about. We've got this panic disorder that happens, this anxiety that happens sometimes without really any kind of awareness or knowledge or any trigger. And then we have what we would call the phobia. So in a specific phobia, this is where we know exactly where this anxiety is going to happen, or this panic attack would happen, because we have a specific fear. And so it's uncontrollable, it's irrational, and but we're going to do everything we can to avoid that object. And so if somebody has a phobia, and it's a real phobia and not just a fear, we don't ever want to make them feel like they're dumb, or that they're being irrational, because yes, the fear is irrational and the phobia is irrational, but it is uncontrollable. There's not much they can do about it. Now, we can do some therapy, which is great, but a phobia is a severe reaction, almost like a panic attack, anxiety attack to a feared object. Now, there's, like I said, differences between the fears and the phobias. The fear is, I'm afraid to be alone. But the person who has a phobia will literally fall apart if they are alone and have a panic attack and almost need to go to the ER and think they're going to die, kind of thing, and do everything they can to avoid it. Same with, if you look at this chart all the way up to animals. Lots of people can have fears of animals, but there's not many people that have a phobia of animals. But again, when they do have that phobia, it is an intense, irrational fear. And then you can see some other phobias like agoraphobia and social phobia. Now, agoraphobia, you're going to see that it's about the fear of having a panic attack, and so you don't go out anymore, so you stay stuck in your house. I used to do therapy with a woman who had agoraphobia, and got her out of the house at some points and helped her to address some of the anxiety, and so that she could feel a sense of control over her life. Now, how do we do that? Well, we're going to do some therapy by helping the individual to relax, because you can't be anxious at the same time that you're relaxed. So we give her some relaxation techniques that she can use as she's in the process of trying to get herself to do to get herself to do some behaviors that are going to get her out of the house. So counter conditioning, if you take yourself back to classical conditioning, counter conditioning is when we link a new positive response to an aversive situation. And so this is, remember how we condition something, we would, have fear, right, be one of the reactions. Remember little Albert, the banging of the two metal bars created a fear in the child. And so how we counter condition it is that we link new positive response to an aversive stimuli. So if a person is struggling with, maybe they had a situation where they went to the store and they had a panic attack. So what we're going to do is we're going to, in our mind, help them to think about walking through the store. We're going to relax them while we're doing it. And then we're going to have them walk down the aisles in their mind. And then we're going to start to maybe we wouldn't go to that particular store, but we might go to a smaller convenience store. And we'll start this process of helping to relax them in a store so that we can get them to the store that they had the panic attack. But at the same time, we're going to be maybe giving them candy or giving them something that's pleasant. So we're going to counter condition that fear with something else that was previously aversive. Obsessive compulsive disorder falls again under the anxiety disorders. And the difference between OCD and anxiety is that OCD involves obsessions. So obsessions are the intense, unwanted worries, but you can't get it out of your mind. And then the compulsion is this strong feeling to carry out an action. So I had a client who was in therapy with me, and he told me that when he was 11, his first experience with OCD was when he was laying in bed. It was really late at night. Everybody was asleep. And his mind just kept telling him he needed to go downstairs and go out to the garbage can and open the garbage can 7 times and then come back inside, and then he'd be fine. But he had to go and open and close the garbage can 7 times. So it was so intense, he couldn't even function. So he went downstairs, he carried out the action, and then he came back and he was able to fall asleep. So needless to say, he's struggled with obsessions and compulsions ever since. But he's more obsessions. Like, his thought process now is just thinking and thinking and thinking and thinking versus these need to do. So he will overthink a lot of things. So a lot of people will say, oh, I overthink things, I must be OCD. And we're talking these obsessions are so intense and they're so unwanted that they just make it so incredibly distressful and dysfunctional. So here's some obsessions is concerns with dirt. Something terrible is going to happen. That's another obsession that my client has, is that there is, after they get into bed, all they keep thinking about is somebody's going to come in and murder them in their sleep. Nonstop, constant obsessive thoughts. And then, of course, compulsions are the hand washing, in and out the door, checking doors, locks, etc. I had a colleague that, or a client that would check doors and would have to check the doors, open and close them, the inside doors as well as the outside doors, open and close them 7 times before they left. So every room in the house had to be checked before they could leave. So these are the kinds of behaviors that we're talking about. So even if you checked and rechecked a door, that doesn't necessarily mean that you have the disorder until it becomes so dysfunctional and so abnormal and so distressing that you would consider it a disorder. So how do we address it? Well, we can use exposure therapy. Exposure therapy is where we would slowly but surely, systematically desensitize somebody to their fears. So in this particular far side, we would never do that. But instead, if somebody had a fear of lizards or a phobia of lizards, I might go ahead and start talking to them about lizards and teach them techniques to relax while we're talking about lizards. And then we'll draw lizards, a couple days later or weeks later. And then we'll start to read books about lizards and, again, doing all the relaxation during that time, slowly exposing them and getting them calmed down as they're talking about or experiencing that, and then eventually move to actually touching that. So that's the exposure therapy that we would use. So PTSD is another type of anxiety disorder. When somebody experiences a trauma, it does not have to be a soldier, but it can be anybody who's experienced any kind of trauma. We would use a technique called prolonged exposure. There's a number of different techniques, but we could use prolonged exposure. And that is where we would have the person tell us the story of their trauma over and over again, and they would keep telling it and keep telling it and keep telling it and keep telling it. Because what we know about the trauma is that because it was so overwhelming to them, think about your limbic system, the amygdala told got ramped up and told the hippocampus, don't forget this, don't forget this. But because it's so incredibly awful, the person just wants to run every time that is triggered because it's so scary and overwhelming. So what we do is try and make it so that it's not scary anymore, and we make them talk about it over and over and over again. And at first it's really, really tough, but then eventually, after most places with good prolonged exposure therapy, the research shows that they can be free from their PTSD symptoms within about 5 weeks if they follow the program carefully. And they've been very, very successful, especially the military has, about kind of removing the influence of these scary, scary traumas. So in understanding the anxiety disorders, again, like the biopsychosocial spiritual explanations, we can look at the different ways we can consider these disorders. So in classical conditioning, we're talking about an overgeneralizing, a conditioned response. In operant conditioning, we're talking about rewarding avoidance. Cognitive appraisal, remember, uncertainty is danger, and so we appraise it incorrectly. Genes, we're predisposed. We'll see that there's heredity, that some of these disorders are passed down. That the anxiety pathways are activated. Remember, we talked about in the last chapter about individuals who are extroverts, and extroverts have low brain function. And so with anxiety disorders, we can see that these individuals are just way more sensitive than others. So there's lots of different ways that we can look at anxiety disorders. And is any of them wrong or any of them right? I think there's probably truth in all of them together. Now, there's just different techniques that we can use. Aversive conditioning is one. We're not going to talk about that because that's not really the disorders as much as it is related to the therapy, but I kind of threw some of these slides in here. So when we're talking about, anxiety and how to kind of address it, we would look at cognition, because cognition remembers your thinking patterns, and so cognition of somebody who's anxious is going to involve worried thoughts, as well as poor interpretation, poor appraisals, maybe some skewed beliefs, negative predictions, and these ruminations. Kind of think of those obsessions. And so the cognition includes these mental habits of hypervigilance, and this is going to accompany a lot of the issues related to PTSD. And so anxious cognitions or anxious thoughts can make it your symptoms worse. And so we've got to address that, whether we address it through medication or we address it through psychotherapy to kind of take those thoughts captive and bring them into obedience to Christ. We also need to address it medically as well. So how can we do it cognitively? Well, there is a couple of different schools of cognitive therapy. The first one is Albert Ellis's rational emotive. So we're going to challenge those irrational beliefs. We're going to lovingly, are you sure? Let's talk about them. Let's look at the basis of where that belief comes from and try and get an individual to see it differently. And then Beck also has some work in cognitive therapy for depression, is that we see that a lot of people, their cognitions are distorted, and so we want to address those distortions. And again, kind of challenging like Ellis's work, but really challenging those distortions, that those things are not quite accurate. Now, Meekenbaum comes up and he says that he's got this stress inoculation training because he believes that it's better for us to address anxiety by preventing it. And so in stress inoculation training, he is working on helping individuals to refocus and reframe their life and practice healthy thinking so that when they are faced with a stressor or difficulties, that they're able to stand up under them and that they aren't going to fall to the distortions and the irrational beliefs that are framing their thinking. So remember, just look at that definition. Cognitive therapy helps people alter their negative thinking that worsens depression and anxiety. So biology and anxiety, there is some interesting research that studies show that identical twins, even raised separately, develop similar phobias. So there is, again, some real support to the idea that there is heritability of anxiety and some other disorders that we have. And then, of course, the differences that we see in temperaments. People with anxiety have problems with the gene associated with the levels of serotonin. So that, again, kind of breathes more or gives more support to this idea that there is biological relationship to anxiety. That does not mean, however, that you must treat it with medication, although that can be helpful. But we can also change our thinking, and changing our thinking can change our brain structure. We already know that because if you experience a trauma, it changes the way you think. So therefore, if a trauma can change the way we think, then the way we are thinking can be changed, which can then change our brain structure. So we can do that bidirectional argument. Some really interesting information about our brain and anxiety. We see that traumatic experiences can burn fear circuits into the amygdala, and these circuits are later triggered and activated. Anxiety disorders include an over-arousal of brain areas involved in impulse control and habitual behaviors. So look at this OCD brain. There's activity in the anterior cingulate cortex, which monitors our actions and checks for errors. Okay, so we're going to go ahead and stop here because we've kind of finished up the anxiety part of the chapter, and so mood disorders is next, and so Dr. Gaddis will finish that for you then.